Hello and welcome to the Spine and Nerve Podcast. My name is Dr. Brian Joves.
And my name is Dr. Nicolas Karvelas.
And thank you guys for joining us today. We are going to continue our conversation on persistent spinal pain syndrome today. Today, actually going to go back to some journal clubs that are more of the legendary status or the original groundbreaking articles that kind of led to some of the way that we think about persistent spinal pain at this point. And so, before we get started, I just wanted to say thank you again for listening. I hope that you guys are finding this valuable. This journey into the back to basics segments has been really gratifying because of how many people have reached out and said that they're finding value and utility out of what we're providing. So please keep reaching out to us. We appreciate that. If you like these episodes, please share them with your co-residents, your attendings, your students. Share them wherever you can. The more people that hear it, the better for us, so that we can continue to educate everybody. And also, please leave us a review because we really appreciate that. But without further ado, Dr. Karvelas, would you like to introduce the articles that we're going to be covering today?
Yeah, so today we're going to cover a couple of articles. As Dr. Joves mentioned, definitely a landmark article by Dr. North and his colleagues. Real quickly, before we jump into those couple of articles, I just wanted to give a brief review of what we had discussed in the first podcast where we brought up persistent spinal pain syndrome. So, like I said, I just want to briefly review the definition we brought up, and then a little bit of the epidemiology and pathophys before we jump into Dr. North's article. So, as a reminder, the definition of persistent spinal pain syndrome, which terms that we continue to use and that we've previously used in the past: post-laminectomy syndrome, failed back surgery syndrome. But in terms of this new proposed term, persistent spinal pain syndrome, as a definition, is not a single diagnosis, but rather an encompassing term that includes persistent painful disease processes of spinal origin linked to the predisposition of the human spine to develop painful pathology over time. The distribution of symptoms can be axial and or radicular, and even though commonly lumbosacral, can be cervical or thoracic, spinal surgery, importantly, may or may not have occurred and may or may not be one of the primary contributing causes. In terms of the epidemiology, as we discussed, especially since we're continuing to try to optimize that definition, the epidemiologic studies are going to have a large range, and because of the continued work on optimizing that definition, there can be some improvement in terms of those epidemiologic studies in terms of what patients are included. But bottom line is, based upon the best available epidemiologic studies to date, persistent spinal pain syndrome is common, with studies documenting 10 to 40% of patients developing this disease process after spinal surgery. And in terms of the pathophysiology, so as we've discussed, very complex, very multifactorial. That being said, some of the most common and best described pathophysiology contributors would include epidural fibrosis and then adjacent level syndrome, which we've discussed in detail. So now moving on to the articles, and as Dr. Joves and I brought up, we're going to start with Dr. North's article, a very important landmark article, which obviously we appreciate him and his colleagues contributing to this field. And sorry, the motion sensor in my room with the light there. But so this article, Dr. North and his colleagues published in 2005 a landmark article titled Spinal Cord Stimulation versus Repeated Lumbosacral Spine Surgery for Chronic Pain, a randomized controlled trial. So this was a prospective randomized controlled trial of obviously spinal cord stimulation versus reoperation. 50 patients were randomized to either one of these treatment arms, and they were followed for, on average, about 3 years. In terms of the results of the study, and sorry, real quickly before I jump into the results of the study. So a couple of things about what type of patients were included. So these were patients that did meet criteria for surgical intervention, and essentially meaning that they had, refractory symptoms with concordant findings on physical exam as well as on imaging, with that imaging showing nerve root compression. So, these were patients that would be reasonable candidates for considering reoperation. Now, of course, from an exclusion standpoint, what we've brought up in the past, when we're in these patients are tough because they're patients with severe chronic refractory pain. Their spines have a lot going on. Sometimes multiple surgeries. So it's important to kind of work our way through all of that history and imaging findings and exam findings to make sure that they don't have progressive neurologic deficits, they don't have concerning changes in bladder and bowel, they don't have red flag signs and symptoms for malignancy, they don't have significant dynamic instability, because those would be the reasons to that we would not necessarily be going down the spinal cord, the neurostimulation route, the spinal cord stimulation route, or other non-surgical treatment options. Those would be the situations where we definitely would at least want them to be evaluated by a spine surgeon. So obviously, part of the reason I'm bringing that up is those were the patients that were excluded from this study with Dr. North. Now, the last thing I'll mention is what they defined as success, because we're going to bring up the percentages of patients that had success or not. So success was defined as at least 50% improvement in the pain score, VAS pain score, as well as the patient reporting on a questionnaire that they were satisfied with the treatment. Essentially, they would go through all the workup and the surgery or the spinal cord stimulator implant, that they would do all that again and they were satisfied with the treatment. So that was what they defined as success in the study. So all that being said, in terms of the results, so ultimately 45 patients were available for long-term follow-up. And what they found was that more patients in the spinal cord stimulator group achieved success, which we just defined there, compared to the reoperation group. So it was essentially 47% versus 12%. So definitely, statistically significant there. Now, the other important thing is that these patients were allowed to cross over after they had their initial treatment, whether that be reoperation or spinal cord stimulation. And when you look at that data, a couple of things jump out. So number one, the number of patients that did ultimately cross over were significantly more in the patients that underwent repeat spinal surgery. So for those patients, 54% of them ended up crossing over to have spinal cord stimulation treatment, in contrast to 21% of the patients who underwent spinal cord stimulation crossing over to attempt to see how they would do with reoperation. If you look at the rate, so that primary outcome of success that we discussed, if you look at the success rate, not necessarily based on the initial randomization, but based on the final treatment, whether that was ultimately spinal cord stimulation versus versus another spine surgery, there was still a significantly increased success rate in the spinal cord stimulator group, with the values being 52% versus 19% success rate. So fairly similar to the initial values. The other really important outcome that they looked at was opioid utilization. Obviously, that's always something that we are looking at in these type of studies. And so essentially what they found there was, for patients whose opioid use stabilized or decreased, that was much more likely to be a patient that underwent spinal cord stimulation. So essentially, 87% of patients who had spinal cord stimulation treatment either stabilized or decreased their opioid use, in contrast to 58% of patients who underwent spine surgery. And patients were much more likely to increase their opioid use after spine surgery. So 42% of the patients who underwent repeat spine surgery actually ended up increasing their opioid utilization, in contrast to only 13% of patients who underwent spinal cord stimulation treatment. So taking all that data together, the ultimate conclusion of the article and of the authors was that spinal cord stimulation is significantly more successful than repeat spine operations by multiple outcome measures in carefully screened and selected patients with persistent spinal pain syndrome.
Yeah, and I mean, I think we've been reading this article for obviously 16 years at this point. It's been referenced in just about every neuromodulation publication since it was first released. And I think, at least for us as practitioners who do this on a regular basis, I feel like this study, obviously a landmark study, but it's become so common in our thought process that I don't think we always understand just how groundbreaking this article was in 2005, right? I mean, from purely a technology standpoint, I mean, this article was published in 2005. You're using, these patients were treated before that. That's how they have this long-term follow-up for them. And so you have patients that were treated in the very early 2000s. So now with, something about 20 years of 20-year-old technology that was utilized to treat these patients, and comparing them to what was considered the standard of care at that point, which was reoperation. And to be able to have such a significant difference in a pretty decently powered study as far as pain studies are considered especially at that time, a good number of patients that were enrolled in the study. This was a very, very important kind of fork in the road for treating patients that had already had back surgery. And I think that as somebody who has read this article 100 times and has referenced it, 20,000 times at this point, like, I think we don't always give it as much, or maybe I don't always focus on how important this study was, right? Like, this was a big deal when the study was published, and it kind of set forth everything that has followed since that point in terms of really focusing on neuromodulation and focusing on these waveforms and trying to find more ways that we can get better evidence of how neuromodulation is working for our patients, and has subsequently set up every single big study that has followed, that has led us to having the mountains and mountains of data that we now have to support utilizing these devices for our patients.
Yeah, no, I think that's well said. I mean, in medicine, we definitely always, stand on the shoulder of giants, and I think that's very true in this case, with these authors and with that article. But so the last article, well, there's kind of a couple articles I ended up including, because one of them's kind of a review article. It's relatively older, so I ended up briefly just reviewing that one, or briefly summarizing that one, and then also including a little bit more recent article as well. So because obviously with Dr. North's article, one of the reasons that article is even there's so much motivation behind doing it is because we know from patient outcomes, clinical experience, and obviously the data that is there, that doing repeat spine operations, the success rate is not necessarily what we as clinicians and obviously what patients are looking for in terms of success rates. So just kind of addressing those exact numbers, a couple articles I wanted to discuss. So the first one, as I mentioned, is more of a review article. This was published in the 1990s, specifically 1993 with Dr. Nichemsen. It was titled Evaluation of Results of Lumbar Spine Surgery. And essentially, he published this review article and he was calling for a critical consideration of the risk and benefits of repeat spine surgery, and caution with frequent utilization of repeat spine surgery without clear and strong indications. So what we had kind of brought up before in terms of progressive neurologic deficits and significant dynamic instability, and in part this article, his rationale behind it was what he was seeing in terms of low success rates, both in terms of what he was seeing at his institution as well as in the literature. And in his literature review that he did for this article, what he documented was the success rate of the first spine surgery being around 50%, but then the second surgery being around 30%, third surgery 15%, and 5% for the subsequent fourth surgery. So clearly, a significant progressive decline in the successful outcomes for the patient. And as I mentioned, that was a relatively older article and a review article. So there was a more recent article published in 2012. This was published by Dr. Arts and his colleagues, and it was titled Clinical Outcomes of Instrumented Fusion for Treatment of Failed Back Surgery Syndrome, a case series of 100 patients. So this was a single center cohort study. They defined failed back surgery syndrome as persistent chronic low back pain plus or minus leg pain lasting greater than 1 year, refractory to one or more spine surgeries. So those were the patients that ultimately were included. Obviously, the objective of their study was to evaluate the global perceived recovery and functional status of the patients after fusion for treatment of failed back surgery syndrome, which, as we discussed, may ultimately be discussed as persistent spinal pain syndrome. So, in terms of the methods of this study, this was, as I mentioned, 100 patients who underwent instrumented spine fusion from 2004 to 2007 for failed back surgery syndrome, as we defined above, that persistent pain for greater than 1 year with one or more surgeries. In terms of the outcome measures they looked at global perceived recovery. They looked at pain on a VAS score. They looked at Roland Disability Questionnaire for sciatica, and they looked at Oswestry Disability Index. And essentially, 82 patients of the 100 were ultimately available for long-term follow-up with an average of 15-month follow-up. And what they found was that 65% of the patients had what they documented as an unsatisfactory outcome, which essentially was they had no difference in their symptoms and or worsening of their symptoms after the surgery. So, essentially 2/3 of the patients having that undesirable outcome. The majority of the patients documented on their outcome measures, including the VAS score, essentially moderate to severe pain and significant disability after the fusion. So, essentially, the majority of patients not only having a unsatisfactory outcome from their global perceived recovery score, but then also having the same, if not worse, pain and function. So essentially, the author's conclusions were, that the present study showed disappointing outcome of instrumented fusion for treatment of failed back surgery syndrome in terms of perceived recovery, functional disability, and pain. And conservative management should be considered, and careful evaluation and selection is critical. So, a similar thought process to what the first landmark article we brought up found, and obviously this data is what kind of drives those studies, like Dr. North's article that we originally brought up.
Yeah, and so I think one of the things that we want to emphasize is that we're not trying to say that surgery is not a good option when it's needed, right? Obviously, Dr. Karvelas has talked extensively about the things that would require surgical intervention, or at least, appropriate surgical consultation, right? Progressive neurologic deficits, bowel and bladder changes, concerning for things like cauda equina or myelopathy. If we're talking about the cervical spine, gross instability. Also, when we start thinking about these patients, talking about their opioid requirements, talking about their comorbid psychiatric illnesses, a lot of those other things come into play. But for patients that don't have any of those other findings, I think we really have to think about whether or not repeat surgical intervention is ultimately the best thing. And I think obviously the North study started recruiting patients 20 years ago. The subsequent study was about 10 years ago. The data has continued to compile that short of having progressive neurologic deficits, there are a lot of times better options to be able to help patients with their pain and to improve their quality of life, and to be able to just generally get them to a better place.
Yeah. And so our plan is, as we wrap up this series of 3 podcasts addressing persistent spinal pain syndrome, we're in the next week or two, we'll do a case presentation, and we'll bring up a more recent neurostimulation article associated with that specific patient in terms of a little bit more recent data.
Yeah. And just as reference, I mean, obviously these are more landmark articles. They are older data. We have, I think, more recently covered some of the literature on dorsal root ganglion stimulation, on DTM therapy. Recently there was an article that was placed not regarding this patient population, but about diabetic peripheral neuropathy, and got our first extended indication for neuromodulation from indication by the FDA for neuromodulation. And so obviously the data has continued to grow. Studies continue to be ongoing. We are always looking for ways to continue optimizing these therapies and all therapies for patients. But yes, as we kind of look towards next week, we will definitely find something that is a little bit more recent, that's going to be pertinent to the way that we are currently managing patients. Thank you guys for listening. Dr. Karvelas, do you have any closing comments or concerns?
No, that's it. Thank you.
All right. If you guys are watching the YouTube channel, I am wearing my 49ers jersey. It is about to be the first week of the NFL season. We will be watching along with all of the rest of you and rooting for our teams. But until then, please stay tuned for those legal disclaimers. Leave us a review. We really appreciate it. And we will talk to you later.